Welcome again. This is Dr. Viva. So we are done with adult lines and tubes. So now we will be moving to pediatric lines and tubes. So I have divided this session into two parts. So we will be discussing a few lines and tubes in session one and the rest of the lines and tubes in session two. Okay. So without waiting, I think we should start with the session. So pediatric lines and tubes are basically important because many a times in the examiner's notes, they have mentioned that candidates are not very familiar with pediatric imaging, including pediatric lines and tubes. So in order to identify which line is placed and what is the exact position of the line, whether there are any complications associated with the particular line and tubes in pediatric age group, so you should be knowing about that. Okay. So that was the overall background why we are going to learn about pediatric lines and tubes. So coming to the first line. So first we are going to discuss is umbilical arterial catheter. Uses of umbilical arterial catheter are for continuous blood pressure monitoring. Second is frequent ABGs, and third useful in critically ill neonates. What is the course of the catheter? So course of the catheter is inserted via umbilical artery. So there will be umbilical cord over here. In umbilical cord there will be two umbilical arteries and one umbilical vein. So these are the two umbilical arteries. So if you put a catheter through the umbilical artery, it will go like this. So basically it will go downwards into the pelvis first, and then via internal iliac artery, it will go into common iliac artery and then further into the aorta. Okay. So that will be the expected direction of the umbilical arterial catheter. We will also discuss umbilical venous catheter and how do you differentiate umbilical venous from umbilical arterial catheter based on the direction of the catheter course. Okay. So what is the ideal tip position? So the tip of the umbilical arterial catheter can be placed at high position or low position. So high position, it should be between T6 to T9 vertebra so that there it will not occlude any major arteries. Okay. So ideally, why T6 to T9? Because there are hardly any major arteries arising from that particular segment of descending aorta, and the low position is between L3 to L4 vertebral level. Okay. What if it is malposition? If it is too high above T6 vertebral level, then there are high chances and the risk of major vessel occlusion such as subclavian artery or carotid arteries. If it is too low below the L4 vertebra, then there will be bifurcation of the aorta. The tip of the umbilical arterial catheter might go or might lie into common iliac arteries. So there will be increased risk of thrombosis. Okay. If it goes into one of the visceral branches, that will cause organ ischemia, especially renal or mesenteric ischemia. And if it is into the iliac arteries, then that will cause limb ischemia. So this is how the umbilical arterial catheter will look like. So this is the expected location of umbilical cord. So the umbilical arterial catheter will first go down. Okay, that will go down into the pelvis, and then through internal iliac artery, it will go up and it will lie on the left side of the vertebral column because that is the expected location of the aorta, thoracic aorta as well as abdominal aorta. So this is high placed umbilical arterial catheter between T6 to T9 vertebra. Now we'll go to umbilical venous catheter. So this is in the umbilical cord, there will be two umbilical arteries and one umbilical vein. So you have to cannulate umbilical vein. So if the catheter goes into the umbilical vein, then ideally, because of the course of the umbilical vein is such that the catheter will straight forward go upwards. It will not go downwards as we have seen in umbilical arterial catheter. So through the umbilical venous catheter, the catheter will progressively move upward into the left branch of portal vein, then ductus venosus, and then at the expected location of junction of IVC and right atrium. Okay, what are the uses of UVC? Rapid vascular access, fluid resuscitation and medications, also used for giving total parenteral nutrition, also for exchange transfusion. What is the course of catheter? We have already discussed this from the umbilical vein into the left portal vein, then from left portal vein into ductus venosus, and then IVC and right atrium. The ideal T position should be at the IVC and the right atrial junction, just above the diaphragm, at the level of approximately at the level of T8 and T9 vertebral level. What if it is malposition? If it is into the portal vein or hepatic vein, then hepatic necrosis or portal vein thrombosis might happen. If it goes into the liver parenchyma through rupture of the tiny vessels, then there will be hepatic injury or hepatic abscess formation. If it is too high, if it goes into the right atrium, then there will be arrhythmia, or sometimes there will be wall injury of the right atrium, and patient might land up into pericardial tamponade due to hemopericardium. If it is too low into the IVC, then there will be ineffective drug delivery and thrombosis risk. This is how the umbilical venous catheter will look like. It will straightforward go upwards, and the tip of the umbilical venous catheter should lie at the expected location of junction of IVC and right atrium. Okay, there will not be any downward course as seen in umbilical arterial catheter. Okay, this is how you are going to differentiate umbilical venous catheter from umbilical arterial catheter. Another differential is umbilical venous catheter, since it goes into the IVC, it will lie on the right side of the vertebral column. However, like we have seen before with umbilical arterial catheter, it will lie on the left side because of the expected location of aorta. Moving forward, there is PICC line, peripherally inserted central catheter. What are the uses for long-term IV access, administration of antibiotics, chemotherapy, and also for parenteral nutrition? Repeated blood sampling can also be taken from PICC line. What is the course of the catheter? Usually inserted by a peripheral vein, either basilic vein or cephalic vein. Ideally, basilic vein is preferred. Then the catheter goes into the axillary vein, then subclavian vein, and then into the SVC. Ideal tip position at the KO-atrial junction, like we have discussed. What if it is malposition? If it is too high into one of the proximal veins, then there will be poor drug delivery, and there are high chances of developing thrombophlebitis as well as thrombosis of the vein. If it is low position, such that in right atrium, then there are risk of developing arrhythmias along with cardiac injury. If it goes into ipsilateral or contralateral veins, then there will be risk of malfunctioning and thrombosis of that particular vein. Extravascular placement, there will be hematoma formation, some tissue injury over there. This is how PICC line will appear. Okay, if you can see over here, so PICC lines are not readily visible to human eyes because they are very thin, around 4 French, 5 French. So we have to look properly. Sometimes the tip of the PICC line is not very well seen. So that is the reason we have to look for whether it is going on the right side or going into the IVC or ending into the subclavian vein. Coming to the endotracheal tube, we have discussed endotracheal tube when we were dealing with series of adult lines and tubes. So what are the uses of endotracheal tube? For airway protection, for mechanical ventilation, and for oxygen delivery and suction. The course of the catheter, either we can put it via nose or mouth, then goes into oropharynx, larynx, and trachea like this. The ideal tip position in adults, like we have discussed, it should be ideally 3 centimeter from the carina. However, in neonates, it should be at the level of 1 centimeter from the carina. If malposition, then what happens? If it is too high, then the risk of accidental extubation and inadequate ventilation will be there. If it is too low, it can go into right mainstem bronchus. There will be unilateral lung ventilation and contralateral lung collapse. If it is esophageal intubation, then there will be no effective ventilation. Patient will land up into hypoxia and patient might die. Okay. This is how endotracheal tube will appear. So this is the endotracheal tube. Now moving to gastric feeding tube. So it is called as gastric feeding tube and not nasogastric tube if we are only provided with chest X-ray and the facial part is not included in the radiograph. Okay. So it is difficult to ascertain whether it is put via nose or via mouth. So that is the reason it is safe to say gastric feeding tube instead of definitively labeling it as nasogastric tube or orogastric tube. What are the uses? For enteral feeding, for gastric decompression, and also for medication administration. The course of the catheter, like we have discussed, can be put via nose or oral cavity, then goes into the oropharynx, esophagus, and stomach. Ideal tip position should be within the stomach and well below the gastroesophageal junction in order to prevent aspirations. Okay, the tip should lie ideally in gastric body and antrum. If malposition, if the tip is still in the esophagus, then there are high risk of aspiration along with ineffective feeding. If it goes into airway or lungs, then serious complications might happen, such as pneumonia, aspiration formation, and lung injury. If it goes beyond pylorus, then there will be post-pyloric feeding. Okay. If it is coiled or kinking into the esophagus, then there will be inadequate feeding, feeding failure. Patient might develop aspiration pneumonias. This is how gastric feeding tube will look like on the chest radiograph. Now, coming to intercostal drainage tubes, the uses are to drain air, fluid, or blood along with pus. It helps in lung re-expansion. Course of the catheter inserted through the intercostal space, then it goes into the pleural cavity. If the indication is to drain pneumothorax, then the tip of the intercostal drainage tube is pointed anteriorly and superiorly. And if it is the indication is to drain pleural effusion or hemothorax, then the tip of the ICD tube is directed posteriorly and inferiorly because of the dependency. Ideal tip position, like we have discussed for pneumothorax, it should be in the apex and anteriorly placed. For fluid collection, it should be placed posteriorly and inferiorly. What happens if ICD is malposition? If it is subcutaneous placement, then there will be ineffective drainage or no drainage. Okay, subcutaneous emphysema might happen. If it is placed into the lung parenchymal injury happen, patient might develop hemothorax in future. If it is too shallow, then there will be ineffective drainage. If it is too deep, the tip of the ICD might irritate mediastinal structures. There might be mediastinal organ injury and ineffective drainage of the pneumothorax or pleural effusion. If it is placed into fissural position, then there will be poor drainage. This is how ICD catheter will look like. Okay. Then the Replogel suction catheter. The uses are for continuous suction of the upper GI tract, commonly used in esophageal atresia to prevent aspiration, because if there is blind ending proximal pouch, then there will be continuous accumulation of the mucus within the blind ending proximal pouch, and the mucus will then go into the trachea and patient might develop aspiration pneumonia. So for that reason, a Replogel suction catheter is put. So this is the endotracheal tube. This is the suction catheter, ideally placed in the proximal portion of the pouch, dilated pouch, can be inserted via nose or oral cavity, then goes into oropharynx and esophageal pouch, proximal blind ending. Ideal tip position should be well within proximal esophageal pouch, typically around T2 to T4 vertebral level. If it is malposition, if it is too high, then there will be inadequate suction and aspiration risk. If it is too low, then there will be ineffective decompression of the proximal pouch. Okay, if it goes into trachea, then there will be severe complications such as respiratory distress or high risk of aspirations. If it is coiled, then there will be poor drainage, ineffective drainage, and continuous secretion and accumulation within the proximal pouch. Now coming to ECMO. So extracorporeal membrane oxygenation. So what is ECMO? So sometimes you might see two tubes. One is a draining tube and the another is reinfusion tube. So what is the function of the draining tube? It will the deoxygenated blood will go from draining tube into the ECMO machine, and in ECMO machine there will be CO2 pulling out from the blood and putting oxygen into the blood. So deoxygenated blood will convert into oxygenated blood in ECMO machine, and then once the blood is oxygenated, then the purpose of ECMO machine is to push that blood via reinfusion tube into the systemic artery. Okay, so basically the uses are to provide cardiac as well as respiratory support in critically ill patients, use in severe respiratory failure, cardiac failure, and neonatal distress. Course of the catheter. So there are two types of ECMO tubes. One is veno-venous, another is veno-arterial. So we have discussed veno-arterial over here. So what is veno-venous? From the vein, So the blood, deoxygenated blood will go from the vein into right atrium, and from right atrium, then it will go into ECMO circuit, and ECMO circuit will be, again through the reinfusion catheter, the blood will return to right atrium. So the blood will always be on the right side of the heart. Okay. And then from right atrium to right ventricle, and then it can go into the systemic circulation. Okay. What is veno-arterial? In veno-arterial, deoxygenated blood from vein will go into right atrium, then ECMO circuit, then return to the arterial system, either aorta or carotid vessels. Ideal tip position, the return cannula in veno-venous, right atrium directed towards the tricuspid valve. And if it is veno-arterial, then the reinfusion or return cannula will be placed into major arteries such as aorta or carotid artery with good adequate flow. What happens if there is malposition? If it is too proximal or too distal, then there will be poor flow, or problems might happen with recirculation circuit of the ECMO machine. If the cannulas are placed against the vessel wall, then there will be reduced efficiency and there will be hemolysis risk. If it is into the cardiac chamber and if it is not properly placed, then there will be a risk of developing arrhythmias and injury to the cardiac structures, might cause perforation. If there is arterial malposition, then the limb ischemia might happen and there will be poor perfusion of the organs. Now coming to the last catheter, we have discussed this in adult lines and tubes. So pulmonary artery catheter, which is Swan-Ganz catheter. The use of pulmonary artery catheter is for hemodynamic monitoring to monitor cardiac output as well as pulmonary artery pressure. The main purpose is to measure pulmonary capillary wedge pressure, also for the assessment of shock and cardiac function. The course of the catheter ideally put via central veins such as interjugular vein or subclavian vein, then it goes into SVC, SVC to right atrium to right ventricle, then into the pulmonary artery, and then into one of the right or left main pulmonary artery. Okay. Ideal tip position should be in main right or left pulmonary artery, proximal to the segmental arteries, or it can be placed just proximal to the segmental artery. Typically within the central pulmonary artery is a preferred location. Okay, if it is in cases of malposition, if it is too proximally placed, such as in right atrium or right ventricle, there will be inaccurate readings along with high risk of developing arrhythmias. If it is too distal, if it goes too far into the segmental artery, then there will be a risk of pulmonary infarction, pulmonary hemorrhage over there. If it is over wedge position, then pulmonary hemorrhage might happen. There will be false pressure monitoring or reading. If it is coiled or kinked, then again false pressure readings might get. Okay, so this is how Swan-Ganz catheter will look like from IJV, SVC, right atrium, right ventricle into pulmonary artery and maybe into the right pulmonary artery. Okay, so we are done with pediatric lines and tubes, the first session in this series. I'll be uploading this session on FRCR Shorts YouTube channel, so you can go over there and check it out. I'll be uploading the next session sooner. Thank you.